one and all to the live interaction as part of Equilox 2017 on the topic of researching equity in access to healthcare. A webinar on the topic was broadcasted last week, and this is a follow-up session for the live interaction with the speakers on the topic of researching equity in access to healthcare. A webinar on the topic was broadcasted last week, and this is a follow-up session for the live interaction with the speakers on the topic. Very sorry for that interruption. So a webinar on the topic of researching equity in access to healthcare was broadcasted last week, and this is a follow-up session for live interaction with the speakers, Professor Helene Schneider and Ms.Sulakshana. A link to the video of the webinar has been pasted below the video of the live interaction, and it has also been mailed to all the registered participants for the live interaction. We're very happy to have with us our speakers, Professor Helene Schneider, and we're hoping that Ms.Sulakshana Nandi will also join us shortly. So let us start the interaction with a brief recap of the presentation by Professor Schneider. Over to you, ma'am.
Good morning, everybody. So Sulakshana and myself started off with an introductory presentation, and for those of you who haven't had a chance to look at it, what we covered in that presentation was some definitions: equity, access, and equitable access. We then looked at frameworks for researching equity and access, and then building on that framework, Sulakshana then presented the work she's doing in Chhattisgarh state, evaluating equity and access under the RSBY MSBY program. So briefly, we defined access, first of all, as the degree of fit between users, populations, and providers of the health system in the dimensions of availability, the right services at the right place, at the right time, affordability, the ability to bear the costs of services relative to household income, and acceptability, the extent to which health services met the accepted norms and expectations of patients. We also said, and then equity and access, bringing that concept of access together with equity, we defined as the just distribution of healthcare according to need, and brought in notions of vertical and horizontal equity with the notion that greater needs, people with greater needs should access more care, and those with equal needs should have equal access. We said that equitable access should not be conflated with equitable utilization of services, and it was really the prior processes that created the opportunity to utilize services, and the need in looking at equity analysis and analyses not to go beyond the usual focus on socioeconomic gradients, but to include other dimensions such as gender, caste, rural status, and citizenship. So our framework really incorporated those elements: availability, affordability, and acceptability, its relationship to utilization and ultimate needs, and the examination of a number of individual level variables such as socioeconomic status, gender, race, citizenship, and a number of group level variables such as rural urban status, facility, and state or site or region. And then Sulakshana then discussed how she'd adapted the framework for her PhD work in Chhattisgarh state and presented some data to show how she'd developed a vulnerability index to assess geographical equity, dividing districts in Chhattisgarh state into high, medium, and low vulnerability, and how that was inversely related to the distribution of health services in the state, particularly private services being strongly concentrated in urban areas, and the more vulnerable districts relying on public services. And she presented it in the form of a map. So that was our introduction. And so for the discussion, we were interested to know, first of all, whether any of the participants had tried to research equity in access, your experiences in grappling with this, with what is often a very glibly used concept in health systems, but actually not often systematically operationalized, or any questions you had about our presentation or the framework we presented. So over to you, Malu.
Thank you, Professor Helen, for that brief introduction. So we have our questions coming in. The first question is by Tariq Aziz, who is an MPH student from our institution, that is Achyuta Menon Center for Health Science Studies. His question is whether you could tell him more about the South African study that used the REACH framework and more on its findings. No. Just start.
Okay. All right. So the South African study, the REACH study, was in fact a 5-year program of work where we grappled with the concept of equity in access in 4 different districts of the country, 2 rural, 2 urban. 2 of the sites were demographic and health surveillance sites, which allowed us to access some of that information in our study. And we focused on 3 tracer elements. Access would vary by condition, by population group, by health problem experience. So we decided to focus on 3 conditions: antiretroviral access, which was, at the time, in the late 2000s, an emerging program in South Africa. And there were a lot of concerns about whether this big program that promised universal access at the top would actually lead to implementation in an equitable way. The second was TB care, which had been provided for a long time in the health service, but also quite a stigmatized condition, and perhaps receiving less of the high-profile attention and interest than the antiretroviral program. Both of those as conditions requiring ongoing access and trust through the primary healthcare system. And then the third was maternal deliveries, which in South Africa increasingly are happening at hospital level rather than the primary care system, but require coordination between antenatal delivery and postnatal care, between levels of care, and require, on occasion, access to emergency services. So we were interested in the access barriers to maternal delivery as a different form of care to antiretroviral treatment and TB. And we did, it was a big multi-method, multidisciplinary program with quite a big team of players who looked at different angles. So we drew on the demographic and household survey data to look at, for example, need. We looked at how many people, for example, had deliveries in the last year, and defined that as the population in need. And then we did studies at health facility level where we did interviews with people who were using services, looked at the socioeconomic and other profiles of people who were using services, comparing those. We also looked at the detailed questionnaires of people attending the health system, those 3 conditions, on all of the access challenges they experienced, how much it cost to get them to a health service, how much it represented as a proportion of household income, how the distance they traveled, what kind of transport they used to get to the health facility, whether they had lost work attending the health facility, whether their ability to pay, whether they were on grants, their household income, their affordability. And then we also asked them how they perceived the service, whether they felt respected, whether they felt that their condition had been adequately attended to. We also did a huge number of qualitative, in-depth qualitative interviews where we looked at people who'd been users of the system, people who dropped out of the system, and people who'd never gone to the healthcare system. And we tried to understand what might be the barriers at all of those levels.
Thank you, ma'am. And next question is again from Tariq. His query was that in the presentation, it was mentioned that in Sulakshana ma'am's study in India, there were a few qualitative components which inquired inequities in access in detail. So he would like to hear more about those aspects.
Is Sulakshana on the line or not?
I don't think she's.
Sulakshana, are you able to answer?
Yes, can you hear me?
Yes, Sulakshana, the question is, our students would like to know about qualitative aspects of the research. Yes, we can hear you. Did you hear the question? Sulakshana, could you hear our question?
Yes. So yes, the qualitative study. Yes.
Okay, I think I'm not.
Yes, I could.
Unfortunately, we're not able to hear you clearly, Sulakshana. Is your connection all right? Maybe we can just get back to you after like taking a couple of other questions. Would that be all right? Yes, I think we'll have to go ahead with the other questions.
Yeah, sure. My internet connection is not working.
Okay, that's fine, Sulakshana. We'll move on to the next question, and then you can get back to us once your connection is better. Yes, one of our PhD students, Dr. Srinidhi, has a question. He asks, is it really practical to assess health system performance in terms of its efficiency, which is quite often based on when we actually want to explore equity? So do they always go hand in hand?
Okay, that's a philosophical question, I think. And I think well, there's a long answer and a short answer, and I think it depends a bit on your view. My view is that they do. They are different concepts and there are different starting points, but that they are complementary. And that unless we ensure that our health systems are efficient, we will not generate the resources to ensure equity. But having said that, efficiency should not be at the cost of equity, is my view. So you'd find, for example, the cost per capita or the cost per bed in a rural area will be higher than in an urban area because you don't have economies of scale, for example, in urban areas. You'd have a cool infrastructure for fewer people in rural areas. So that may seem inefficient in some respects, but in fact is ensuring some equitable access to services. And so, yeah, I think my view is they're complementary concepts, but I'd be interested to hear what other people think.
Thank you, ma'am. So we have questions coming in from Ms. Rajalakshmi from Chennai. She asks, in case of gender health inequity, women and men have different health risks. So how do we determine that an observed difference in utilization is actually unfair? She goes on to explain it. That is, example, utilization by men in health insurance schemes is higher. So how can research prove that this is inequitable, she asks.
Yeah, okay, so that's also quite a big question, and maybe Sundari, you could also help us through this. But okay. So if one took, let's say, an equal condition, um, so let's say pneumonia in children, illnesses, you could that would affect girls and boys equally. You could look at gender differences there. You could then at a more qualitative in the ability to pay, the affordability, the extent to which women's issues are taken as seriously as men's issues, and the extent to which resources are allocated to access a health system. And then you could also look at the degree of acceptability, the extent to which gender norms operate in the health system that seek to empower or undermine women or treat men differently when they walk through the door of a health facility to women. Having said that, in the South African context, one of the main papers looking, in fact, at gender looked at the gender differences in antiretroviral uptake and adherence, and to some extent outcomes between men and women. And what we found, in fact, is that the women did much better than the men, because health services through maternal and child health programs are geared towards very strongly having women, particularly in the reproductive age group and young children in the health system. So there's a whole lot of barriers to healthcare seeking behavior that relate to notions of masculinity and the extent to which men can take on, for example, the sick role. That's cultural norms that serve to undermine their services and to stain them. That HIV was a much stronger challenge to the identity of men as strong and capable and as providers than they were to the identity of women who were users of health services. So it works in complex ways.
Yes, thank you, ma'am. So one of our PhD students, Bevin, who's working on discrimination, has a question. So he says, in highly unequal societies like India, where there are deep-rooted structural inequalities like caste and so on, how do we define access? In the sense, when viewing the concept of access using the traditional lens and considering solutions like UHC, would that be adequate to address inequities in such societies?
So the concept of access without bringing equity to it wouldn't, and you'd have to bring the two together, the notion of equity. So you would look, for example, at the availability of health facilities or the acceptability or affordability, each of those constructs, and you would see how that varies according to caste and the other equity dimensions, and then you'd be able to comment on the differentials. So it's in bringing the notion of equity with access. Access in itself isn't necessarily an equity-related concept. One has to bring the equity analyses to bear on the answer.
Thank you, ma'am. So based on the qualitative studies that you have conducted, Tariq asks, could you say something about the perspectives of people on access and the barriers in access? Like, what perspectives did you get from the people?
So in South Africa, the health system is, particularly the primary healthcare system, is free at the point of use. So people don't incur user fees, and it's very unusual actually to be asked to hand over even informal payments in the health system. So the costs that are incurred relate to the cost of travel and transport and the opportunity costs of foregone work. And so those would have been ones that people raised, but most significantly was the human quality, the experience of acceptability or cultural access, and the perception that as users of the health system, people are just not wanted there. And we had very strong cases reported to us of people who felt who experienced the health system as actually violent in some ways, emotionally violent, and in some instances, and that's particularly in maternal health system, physically slapped or physically pinched or something during labor. And so that kind of physical violence is not unusual in the health system, and the notion of disrespect and abuse in maternal health system actually is emerging as quite a universal one. It would have centered big on answers and a feeling of deeply unwanted by not universally. When we did a multi-level analysis of the experiences, for example, of respect, it varied quite a lot by facility. And actually, if the average socioeconomic the people was low, they were much more likely to collective disrespect. So it has to how health workers perceive patients as deserving or not.
So a researcher from AMCHS's Aishwarya has a question. She asks, would unmet health needs be a useful concept to assess inequities in access when health needs are unequal?
Okay, unmet need is crucial to understanding access. So access is about addressing need for it has to be understood as relative to the need for services. That's where the equity comes in, and an unmet need would be about unrealized access. Really, the second part was
when health needs are unequal, would unmet health needs be a useful concept?
Yeah. So unequal health needs would require an unequal access response, and to get at what that unequal response needs to be, you would look at differential the differences in unmet need between groups of people.
Thank you, ma'am. So our PhD student Devin has made a comment regarding utilization, the gender component. So he says that they had done a secondary analysis of hospitalization due to stroke by gender, and they found that women were more likely to be treated in public hospitals or alternate systems of care compared to men, and also the expenditure on hospitalization for women was also found to be almost twice as that for men. So this was a finding that they found in one of their secondary analysis. Would you like to add? Just a minute. I think we're facing a technical error. Yeah, so that's okay. So this is a comment that he's made based on a study. So would you like to add to it? Yes, it's good.
That's how that's something gets to something of the gender differences in how they utilization, and probably to look at the level of the household decision making to try and understand those trajectories. So what influences decision making? And maybe it is something about men having greater access to resources to go into. Although what I heard you say is that the women ultimately use more resources, so that's a bit contradictory because you'd expect to pay more in the maybe it has something men don't feel with services. So it's a complex question and would require a lot of qualitative information to understand these barriers underpinning such a complex path of utilization along gender.
Again, a researcher from our institution has asked a question. She actually shares a finding that in a tribal study that they had conducted, it was found that rather than the distance from health facility, it was actually access to modern lifestyle that has impacted the risk factors of non-communicable diseases among tribal population more. So it was not that they had reduced access to health services, but it was access to all the amenities and urbanized lifestyle. So she asks, how do you see this reversal?
So what we're talking about here is access to healthcare, and that might include preventive, promotive services that enable people to live a healthy life. So it's possible that such programs less accessible to people in tribal areas, and because they have greater need, should have greater access to those programs. Access. So a health system exists, and often unequal access to health services is a cluster of factors that would lead to areas or geographical areas of deprivation. The two would go together, reinforce. But the health system is just one aspect of improving health. It's not all of the actions that are needed to address health. So obviously you'd need a broader set of actions at a societal level to improve health. If I may just say, so one of the concepts that we was the notion of hurdle of access. So the one is getting to a health facility. And even if it's available to you, you may not have the ability to get to the health service. And in the input that we gave a few days ago, we spoke about a disabled person in a wheelchair needing a different kind of physical access to your body and able to walk to a health facility. So that's the first hurdle is getting to the health facility, even though it may be equally available. The barriers to getting to the health facility may be unequally distributed. But then the second hurdle would be a hurdle within facilities, a hurdle to access the services that are needed, get good quality care, and to have access to a comprehensive set of services. So it's not just the presence of a facility, it's also what goes on inside there in terms of delivery. And people in tribal areas may be disadvantaged at all of those levels, in addition to having a broader context of social and economic inequalities that act in a reinforcing way with healthcare access inequities.
Renu, our MPH student, asks whether you thought that researching equity is highly context specific.
Yes and no. I think that general definitions, general frameworks that can be applied the specific findings would be, so in our 4 districts in South Africa, we had 4 very different profiles. Obviously, the urban-rural dimension was one, but also historically how the services had developed. In one rural area, for example, there was a very good ambulance service, which for maternal deliveries was quite key to reducing the costs of transport, which is really a very big element of the question of affordability in maternal deliveries, because often it's in the middle of the night, you have to get transport from the neighbours there. It costs a huge amount to do that. And so that district had much lower levels of catastrophic expenditure, and it was much more equitably distributed than the other area. Yes, the specific context specific, but the thinking, the approaches, the general would be transferable to other areas.
Yeah, thank you, ma'am. So a PhD student, Bevin, has another question. He asks, where do informal or non-trained providers fit into all this? They may be acceptable, available, and tick all the requirements of access frameworks, but they may not be acceptable to the health system. So how can they be fit into this or used?
So I think, yeah, that is absolutely key question, and that gets to the dimension of cultural access. That cultural access is the extent to which the norms and forms of delivery offered by the health system meet the needs and expectations of users. And if the needs and expectations of users ultimately are to be treated as a whole human being, censoring a lot their life world, their worldview, their health world, as some might call, making that taboo within the formal health system is a form of cultural violation, and it's a barrier to cultural access. And so that might come out as a big barrier in qualitative work. If people being interviewed feel they can trust the interviewer, they may say that actually I would like, it would be so good if there was a referral and collaborative relationship between traditionalness of care. So I could be free to move between the two, knowing that there's agreement and understanding and an ability to work together around my needs.
Thank you, ma'am. So we have exceeded our time decided for this interaction. So we have time for just a final couple of questions. So Deepa here from Chidamanan asks an interesting question. She asks, how can we convince the policymakers to allocate resources equitably when the issue of equity affects a minority powerless group who are not going to affect the political decisions of the policymakers?
So the one thing would be to get a discourse of equity firmly entrenched, actually, in policy thinking, and it would require quite a lot of advocacy and careful work to show where that might be relevant. So in all frameworks, to ensure that there's an equity dimension to it, in monitoring and evaluation systems, to have equity as one of the core parameters that is part of in the same way that efficiency and might be looked at, to have equity considerations a key part of that, and to get national consensus on what are the key parameters of equity, and to ensure that is monitored over time. So, and yes, as we discussed in the class today, it's about voice and agency, people coming together to demonstrate or to highlight its necessity, it's about finding windows of opportunity to put it onto the agenda and providing the tools and techniques, the science of how to do it, I think is quite key. And that has to happen over a long time, especially when equity is not considered key. But what I know of Indian societies is that, that the democratic ideal in all of the formal statements of the nation and founding documents, that equity would have been there somewhere. So if one can appeal to that, so in South Africa we have a constitution, and we use that extensively in advocacy efforts. One can work with existing frameworks and bring them alive, but also set agendas and activism and civil society, putting it on the agenda of the policymakers and giving them the tools, showing them how it can be done. And also to, civil society do its own equity reports. So in South Africa, we have a civil society that does that, that focuses on equity dimensions and draws it to the attention of the public.
Thank you, ma'am. Mitra asks that whenever we try to address issues related to equity, we predominantly evaluate it based on the concept of affordability. But shouldn't concepts like quality of care and responsiveness by health facilities be given equal consideration to?
Yeah. Yes, the answer is yes, and the framework tries to do that by looking at the notion of availability, which includes physical availability, but also quality of facility, what happens within facilities, and the acceptability, cultural access, responsiveness also can be referred to dimension as well. So we need to bring all three together to properly understand access.
Yes. So the last question would be the National Health Policy document of Indian government, the recent one, speaks clearly of equity as one of its agenda. However, it also gives more power to private sector, which is largely unregulated in this country. So would you consider that the concept of equity, would you see with unregulated private for-profit sector, even strategically position them and we try to have alliances with them, would that be actually practical?
So in general terms, private sector delivery based on market forces would not inherently be pro-equity, because it would go where it's possible to make money. And that would be, for example, much more likely in urban than rural areas. Having said that, the private sector is very large, as I understand it, in India, and constitutes more than half of total utilization in the country. And I think one would need a much more refined analysis of the private sector, who are the key players, to do a kind of stakeholder analysis, where one would differ primary providers, other forms of delivery, and to look at the cultural norms, the approaches operating in each of those places, to also understand how users feel about different elements of the system, the providers, and of receptivity to regulation, basically. So I think the private sector and what one does about the private sector, I think is a big question. I don't think one should give up the public sector. Okay. And I don't think one should transfer funds to the private sector simply because there are more of them and one doesn't know what to do with them. And I think building public health sectors is absolutely crucial. And how one works with the two sectors, I think, is a very, very big question that needs a lot of research.
So this is the last and final question. Priyanka has asked it. She asks, do you think universal health coverage has considered the equity aspect and accessibility issues significantly to reach its goals? Tribals have enough primary health centers in our state particularly, but accessibility has not been considered enough.
So it depends what you mean by universal health coverage. So if it's the health insurance, if coverage means insurance for hospital inpatient care, or if you understand universal health coverage in the broad definition that WHO or we would use in South Africa, equity in access would be one of the first principles one would want to look at. So it's not it's a UHC is a broad umbrella concept under which lots of different ideas sit, and I think one has to be precise what one means by that first. Having said that, the work that Sulakshana has done, and I don't know if Sulakshana can hear us, because she might want to talk about this actually. Sulakshana?
Sulakshana, can you hear us?
Can you hear me? Can you hear me?
Yes, I don't think.
No, we can't.
You're not. Yeah.
The line's not clear enough, so I'll try and answer that. What Sulakshana found for her PhD in Chhattisgarh was that there was an immense drive to recruit tribal populations into the new insurance scheme, RSBY and SBY. And so the percentage of people with the smart card with enrolled was equal across socioeconomic strata or social groups. And even so, how in most parameters in which one looked at it, except the wealthiest quintile were much less likely to want it, so they had but that didn't translate into equitable use or equitable access to services. So the availability of facilities to use in the first place, and then the use of services was inequitable. So it's having universal coverage identified very narrowly as enrollment in a scheme doesn't automatically translate into equity in access and outcomes or utilization.
So that was the last question of this live interaction. Professor Schneider, it has been an honor and privilege as speaker for your patience and your cooperation during the webinar and during this live interaction. It has been unfortunate that we couldn't have Ms.Sulakshana Nandi. We couldn't hear from Ms.Sulakshana Nandi. Yes, due to heavy rains yesterday, she has very poor connectivity and she's not clearly audible. So, but I'd like to thank her for her cooperation and support. All of you had an enriching learning experience. Thank you so much.